Thank you very much. So my topic is the dawn of the new era in the management of type 2 diabetes, which is based on the multi-organ protection. Now first, I'll try to focus or first to compare the conventional management of diabetes to the intensive approach in the management. And you can see in the Eastern Mediterranean, there is 5.8 years delay in the starting the second agent. So we start, for example, metformin until we uptitrate, after we start the second agent, we take 5.8 years delay. And this is called clinical inertia. Now the clinical inertia, of course, we lose control of diabetes, and this may increase the likelihood of the complications. Now, in the diabetes management, there is multiple pathophysiology explaining the diabetes. And there are more than 11 pathophysiology in diabetes. That's why, probably, from beginning, attack on the several front lines immediately after diagnosis is the best. So combination of the treatment is the best. And if you got one agent which can block more than one pathophysiology, that's much better. Looking more in this interesting slide, you will see the difference between the two approaches. If you start the conventional treatment, and then your patient, for example, diet exercise, then one oral hypoglycemic agent, titration, combination, or if the patient is uncontrolled. That's the problem. Now, if you go to intensive and you brought your patient under control and you continue that intensive treatment, even if there are some peaks, they will never exceed 8. That's very good. So you will decrease the likelihood of the complications. That's why combination is the best, and to be intensive is the best. So the best approach in the management of diabetes is intensively to the target. This will reduce the incidence of diabetes complications. That's much important. Now, the first piece of the puzzle of this presentation is this one. Early control, A1C control, should be early, should be intensive to the target, and you should have complementary mechanisms. That's the least number of medicine that corrects highest number of the pathophysiology to get the best outcome. That's the first piece of the puzzle. However, Mr. Chairman, that's not enough. However, A1C control only couldn't lead to best benefits. That's why we have to think about extra glycemic benefits. And that's one of the core principles of this presentation. So the MACE will be reduced if you control A1C, the dyslipidemia and albumin-creatinine ratio, you normalize, you control blood pressure, and smoking, then there are reduction of the MACE. However, what's astonishing that there is residual risk of heart failure whatever you did, and always the hazard ratio is to the right. So whatever intervention you take, still there is residual risk of heart failure. So we can agree now there is residual risk. What's more interesting, if you look to the diabetes or regarding diabetic nephropathy, whatever you did, even with the intensive arm, there is 25% residual risk of diabetic nephropathy. And if it's conventional arm or the traditional treatment, this is 46%. Huge residual risk will persist whatever you did regarding diabetic nephropathy. There are astonishing data showing that from 1980 to 2016, the prevalence of end-stage renal disease increased by 13-folds. And this was mainly due to increase in the prevalence of diabetes. Increasing albuminuria is associated with the increased cardiovascular events and mortality in diabetes, because when you get damage in the vessel in the kidney, there is damage already in the heart. So the second piece of the puzzle in the management of diabetes is this one. You need extra glycemic benefits. That will delay complications, preserve the renal function, protecting the heart, and also extra benefits of the metabolic syndrome, especially in the form of weight loss. That's much important. Looking here, between the candles, the flame of the hope at the Banting House who discovered insulin, that was in 1989. The queen kindles the flame, and the flame will be there, and will be good the team who will find a cure of diabetes. They will go to Canada, and they will extinguish this flame. So until now, the flame will be there. Now, until now, we don't have cure of diabetes, but what we are looking for is the hope of management. And probably the SGLT2 inhibitors we are searching for a new hope for management of diabetes And as Barack Obama said, while we breathe, we will hope. And that's probably until we find a cure, we have to have hope in the management. Interestingly, the dapagliflozin is the agent who put two pieces of the puzzle. I will remind you quickly they are acting on the proximal tubules of the kidneys to prevent the reabsorption of the glucose. This will cause glycosuria, and this glycosuria will put the patient under negative energy balance, which will help him to lose weight. And Mr. Chairman, it's very interesting. If you start this agent in newly diagnosed patients in combination with the metformin, probably you will help the patient to achieve diabetes remission. Because we know diabetes remission from the first diagnosis is very likely if the patient lost 10 kg from the baseline. So these agents are helpful in that point too. Now, looking to the weight, there was significant weight reduction when you add dapagliflozin to metformin. And that's after 24 years. After 2 years, this weight, even the weight loss increased, and it maintains and increased weight loss. That's very important. So there was reduction of the weight and persistent reduction of the weight over time. That's important. And so over 102 weeks, DAPA-treated patients showed reduction in the weight by minus 4.5 kg, waist circumference by minus 5 cm, and fat by minus 2.8 kg. That's interesting. So these agents have excellent extra-glycemic benefit, which is weight reduction. Now, the cardiovascular protection you need tomorrow starts today. As William Osler said, the best preparation for tomorrow is to do today's work superbly well. So when you receive a patient with diabetes, please think how to protect his heart, his kidney in future. We have to do the work today superbly well so we can prevent that, and prevention is much better than cure. Now we can say the DAPA is an intelligent agent which has the following: the glycemic control, the cardiovascular protection, and the kidney protection, and the metabolic properties in the form of weight loss. Now, looking interestingly in the CLEAR study, there was a reduction of MACE by 16%. Here it's very clear, by 16% in the arm who used the dapagliflozin in comparison to the placebo, and those who had previous history of myocardial infarction. It was also protective against hospitalization from heart failure, and again, that was reduced by 27%, as it is clear here. So it was protective for cardiovascular. Let's go for the kidney. As the protection or we lose or we develop or the patient develops diabetic nephropathy, there's increased mortality. So conflict is inevitable, but the combat is optional. And I would say the diabetes is inevitable, but nephropathy is optional. You can't prevent that from the early beginning by educating the patient and by starting wise oral hypoglycemic agents. So my question, Mr. Chairman, is this one: how we can prevent diabetic nephropathy? We all know this diagram from the medical college. We took this in the medical college, but there are 5 stages of diabetic nephropathy, and we always screen the patient at stage 3. That's albuminuria. But there is a secret: you can't prevent diabetic nephropathy from stage 1, which is only there is hyperfunctioning and hypertrophy, increase intraglomerular pressure. And this is present in all patients with a newly diagnosed whether type 1 or type 2 diabetes. So it's present at the time of the diabetes. You can work here, and you don't wait until here. So you can work here. How we can work here? By this. SGLT2 inhibitors in type 2 diabetes is associated with increased natriuresis and attenuation of elevated EGFR, suggesting reduction in intraglomerular pressure. So this agent can stop the diabetic nephropathy at stage 1. There are any data for supporting the stop? Yes. From the CLEAR, it was very clear that those patients who use DAPA, the blue arm, they maintain renal function in much better way in comparison to the other arm. And the summary of this slide is this one. So the rate of the renal events, here I mean increase in serum creatinine, or declining of EGFR, or increasing kidney or kidney-related mortality. So the rate of the renal event was 47% lower in the DAPA arm compared to the placebo arm. So this agent is protective for the kidney too. Now, a practical point we have to remember that the dapagliflozin shouldn't be stopped when you put EGFR less than 60. Please don't stop. Because when you start this agent, there will be some intravascular volume reduction or contraction. And this may predispose to acute kidney injury. So to start with, especially be careful in old age. To start with, you have to have baseline EGFR more than 60. But Mr. Chairman, once you start, there will be some declining of EGFR and some increase in serum creatine. And up to 45 is acceptable, it means it's working, but if it is decreased more than 45, you stop the agent. If it decreases up to 45, it's okay, it means the agent is decreasing intracranial pressure and it will protect the kidney in the future. So, two pieces of the puzzle are there. The first, A1C control and the extravascular benefit, protecting the heart and the kidney and losing weight. So that's the agent which work on the many lines. So I will finish the talk by this one. The highest flying bird on the earth is Propel Griffon vulture. It's very interesting that this bird is the highest flying bird in the world. Now this one confirmed evidence of a flight at an altitude of 37,000 feet above the sea level. Interesting. And this bird caused some accidents with the airplanes in the Scotland. Very high flying bird. And interesting to read about it. But what's very interesting that all in all, and at the moment you say, we are not sure about the future, but at the moment, due to their multi-organ protection, probably the group SGLT2 inhibitors will be the highest flying oral hypoglycemic agent in the sky of diabetes. And thank you very much for your attention.
Thank you, Leah, for your nice presentation. Actually, we are in the cardiology community. We will try to bring these intelligent agents, I mean the SGLT2 inhibitors, to the cardiology more than the endocrinology, and the EMPIRE trial, the DAPA-HF trial, and even the DECLARE trial, all of them are very robust data that's supporting the use of the SGLT2 inhibitors in the cardiovascular diseases, including the heart failure, regardless of the presence of diabetes. We will take a couple of questions, if there is any, please. Yes.
What is the cause behind you cannot use it before GFR below 30? Is it harmful or is it not effective?
So the second question, please.
The second question, can we use it if the GFR below 30?
So first, what's explaining the initial increase in serum creatine, or slight increase or decline of EGFR, is the reduction of intraglomerular pressure. Because there will be reduction of intraglomerular pressure. That's why there will be increase slightly. You are at the stage of, we say the first stage is hyperfunctioning or hyperfiltration. You will stop that. So there will increase slightly in the serum creatine. However, this is very safe. It's working. But you don't start the agent if you're initial. So I put a patient with diabetes, I will check the EGFR, it's normal, more than 60, I will start. If it is below 60, I will not start. After I start, I will follow the patient. If there is reduction of EGFR, but it's not below 45, I will continue. If it's below 45, I will stop the agent. So you don't, because it's basically not effective. If the EGFR is below 50, maybe it's not working. And there will be reduction, or there will be some intravascular, the drug is working by yes, so you lose glucose in the urine. With it, you lose fluid. Okay, so you put the patient at risk of dehydration and more acute kidney injury. So don't start when your EGFR is below or 60 at all. From the beginning, you don't start. There is no need to start because you do worry of intravascular volume reduction and some acute kidney injury.
I think there's no limitation for using SGLT2 inhibitors in diabetic patient when there's a low GFR. And secondly, when the patient with severe peripheral vascular disease, which makes the amputations very likely, the mechanism behind it is still conflicting.
So, yeah.
Any other question, please? And
yes, sir.
On the hierarchy, the metabolic hospitalization, I'm mindful of Hassan Najjar. You know that all these studies highlight the use of these new drugs with the GFR. This GFR cannot be estimated so easily. Can you tell us if you can use the serum creatinine? Can you say at a serum creatinine of 1.5 you cannot use this, use that? Can you?
So I don't have a certain number of serum creatinine because all guidelines established on the EGFR. So what we can do, we can calculate very easily. So just you open your smartphone, you go to Medscape, the EGFR, and then you enter the age and the sex and the gender of the patient, and it will calculate for you. So it will give you a rough estimation. But probably in the EGFR of 1.5 you will not stop. But even at 1.3, if the age, then the EGFR will be different. So still the guidelines are based on the EGFR. I don't have certain number of serum creatinine.
Should we estimate the GFR and then decide whether it's safe or unsafe?
Thank you, Dr. Bayat, for this nice presentation. Most of the this dapagliflozin is a new drug. Most of the doctors they used to prescribe glucophage or metformin. Your opinion?
So still the guidelines are very clear that metformin is the first line of the management of diabetes. But if then you divide your patient. If he is with cardiovascular or renal problems, especially cardiovascular risk factors, then the second agent, please go for DAPA or SGLT2 inhibitor or GLP-1 agonist, as the guidelines are very clear. But on the other arm, what we do support, if your patient is first diagnosis, please don't start sulfonylurea. Don't be aggressive in the patient A1C. Be gentle and start combination of metformin plus, for example, dapagliflozin. For example, this will achieve multiple pathophysiology, reduce weight, and explain it to the patient the new diagnosis. That there is an idea of diabetes remission if he lost 10 kg. And this agent will help that. But don't fight the patient with the sulfonylurea, increasing his weight and putting him in the troubles that he will never get out of it. That's why. And it's preferable in the guidelines if the patient, if he's overweight or he's obese, then we start these agents. So these are. So when the patient is in the home, you know what you do. So if he's very thin, of course I would not think about to start this agent, wasn't forward. But if he's overweight and obese, then I would think about this agent. This is a very good option for those patients.
Because this agent causes significant weight reduction compared to another agent. I have just one comment. And one of the things that recently published, okay? As we know, in the cardiac branch, we use this agent as recommended as class 1A in patients with heart failure, even without diabetes, and should be initiated this medicine before your patient is discharged from the hospital because of the acute decompensation heart failure. Very, very recently, according to very big 2 trials, which is Ingerol and the Dilber trial, have been found that initiation of this agent in patients with heart failure and preserved lung function, not without low EF. Preserved lung function definitely will be significantly decrease the mortality hospitalization because of the decompensation. Thank you very much.
Yes, and in that slide, 90% of the patient, they were with normal basic cardiac function.
Normal EF.
Yeah.
Normal
cardiac function.
Okay, thank you very much, Dr. Bayat, for your presentation, and thank you for all of you. We will close this session, and then we will go to the second.
So, thank you very much. We close the first session, and we will go directly to live case transmission. May I call Dr. Aram Mirza, Professor Omar Godkin, and Dr. Aziz